Welcome to the Cytokine Signaling Forum's highlights from ACR 2021, where authors will take us through their posters and presentations on cytokine signaling, JAK inhibitors, and in this podcast, considerations surrounding COVID-19. My name is Len Calabrese. I'm the head of the Cleveland Clinic section of clinical immunology. I do not have to tell you that COVID has had a huge impact on almost every facet of life this year, and clinical practice has certainly been no exception. Lockdowns and restrictions have changed the way that we manage our patients. And in this edition of our ACR 2021 highlights, we look at the impact of these changes that they've had on our practices.
Hi, I'm Dan Solomon. I'm a professor of medicine at Brigham and Women's Hospital and Harvard Medical School in Boston, and I'm presenting today on behalf of my co-authors who are listed here. Here are some disclosures. And here are some evidence-based medicine references. As we all know that during the 2020 pandemic, our waiting rooms emptied and we quickly switched to virtual visits. This was something that happened in the United States as well as around the world. Virtual visits during the COVID pandemic increased 30 to 40-fold during the first year of the pandemic. And while all clinicians have experience with episodic telephone visits, ongoing care using video is an area where few of us have extensive experience. Many suggestions were made available through social media, but really little data exists on how effective virtual visits are. Specifically in rheumatology care, where the physical exam is so critical, we all wondered whether the care we were providing was effective. We had the opportunity during the COVID pandemic to study virtual visits compared to in-person visits in the setting of a learning collaborative. We had pursued a learning collaborative in 2016 and 17 called Traction. A learning collaborative is a group quality improvement project that entails developing a change package with faculty, selecting teams, and in this case, these teams were from around the United States. And typically, a learning collaborative has an in-person learning session where faculty discuss the change package and aspects of the learning collaborative, and then ongoing learning sessions can occur in person or virtually. In the setting of our learning collaborative in 2020, this all happened virtually. Our earlier version of the Traction Collaborative focused on treat to target in rheumatoid arthritis. And our outcome of interest was adherence with treat to target based on several different aspects of treat to target, including disease activity measurement, identification of a disease activity target, modification of treatment based on disease activity measurement and target, and shared decision-making. In our prior randomized trial, Traction, in 2017, we found that the 11 sites that were involved started out with an adherence close to 11%, but after the 9 months of the learning collaborative, their adherence went up to approximately 50 to 55%. The aims of our current dissemination study were first to test the feasibility of a wider dissemination methods for the Traction Learning Collaborative. And we've presented some of this in poster number 815 on Sunday of the ACR meeting. Today, I'm going to discuss specifically comparing treat to target in the setting of virtual visits versus in-person visits. This was a single-arm demonstration project. And initially, the face-to-face kickoff had been planned for May of 2020, but it went completely virtual and started in October of 2020, right in the middle of the pandemic. Again, this allowed us to further examine virtual learning collaborative and to compare treat to target adherence during virtual visits to the in-person visits. We recruited 18 sites representing 10 states across the United States and the District of Columbia. None of them were in the original Traction Learning Collaborative. Here's a schedule of our 6 months of the Learning Collaborative. During month 0, we had a kickoff. This was all virtual, a 5 to 6 hour meeting where we had all faculty involved. They lectured, we discussed treat to target, we discussed PDSAs, or Plan, Do, Study, Act cycles, and there was substantial time for team building. Learning sessions 2 through 7 are shown below, and each one was focused on a different aspect of the learning collaborative with different faculty engaged. They were all done virtually. Here's the data collection form that was used. We asked sites to collect data on 20 to 25 rheumatoid arthritis patients in the week before each of the virtual monthly seminars. We asked them to give us a modicum of information, all de-identified, focused on the aspects of treat to target that we were most interested in for the adherence calculation. So the disease activity measurement, the target, whether disease modifying agents were changed if patients were not at target, and any evidence of shared decision-making when decisions were being made. Again, our primary outcome was the percent adherence with treat to target, and this entailed the presence of a recognized disease activity measure, identification of a stated disease activity target, documented plan for treatment if the disease activity measure was not at the stated target, and if decisions about treatment or target were being made, description of the shared decision-making process. Here's some data on our 18 sites. You can see that some of them were academic, some of them were not. They were ranged in size based on the number of RA patients, from relatively small to large. The virtual visits during the learning collaborative, some sites had very few virtual visits, and some had a large proportion. The types of visits that we included were primarily routine visits, as shown below, and there were some urgent and some initial consults. You can see that over this 6 months of the learning collaborative, the mean percent adherence went from 50% up to about 75%. So this is starting at a higher baseline than we saw about 4 years ago with our original Traction Learning Collaborative. And we saw a similar robust, statistically significant increase over the 6 months. If we look at the specific aspects of treat to target that we've examined, disease activity measure, target, changing DMARDs, and shared decision-making, you can see that the in-person at a higher rate compared to virtual visits for everything except shared decision-making. However, it's important to note that over the months that we measured treat to target in-person and virtual visits separately, you can see that the virtual visits started out much lower and then caught up to the in-person visits. So this is in green and this is in red. The in-person in red, again, was much higher. So some of the limitations is that this was only done in the United States and only among 18 US sites. We allowed the sites to self-assessment of treat to target adherence, and clinical outcomes were not examined, but we know that treat to target is associated with improved clinical outcomes. So in conclusion, self-reported adherence with treat to target improves during a virtual learning collaborative. Adherence with treat to target during virtual visits improved similarly to in-person visits. And a learning collaborative helped improve adherence with treat to target during virtual visits to the point where adherence was very similar to the in-person visits. I want to thank you for your attention and hope you enjoy the ACR this year.
Hi there, my name is Philip Robinson and I'm from the University of Queensland, and I'm presenting this work today on behalf of a number of authors listed here, and it's the minimal impact of the COVID-19 pandemic on patient-reported disease activity and health-related quality of life in patients with ankylosing spondylitis receiving bimekizumab. So bimekizumab is a monoclonal antibody that inhibits both 17A and 17F, and it's been demonstrated to be pretty efficacious and pretty well tolerated in those with AS for up to 3 years in the 2B Agile study. So there are a number of different findings from real-world studies about the impact of the COVID-19 pandemic on patients and quality of life in those with ankylosing spondylitis, and they've been variable. So in this study, we wanted to use this open label extension study to assess what the impact of the COVID-19 pandemic was, and also obviously the changes in society that went on health-related quality of life and patient-reported disease activity. in this group of ankylosing spondylitis patients getting bimekizumab. So patients completed the week 48 of the Be Agile study, were then eligible to enter the open label extension, and a total of 303 patients were randomized at baseline, and approximately 84% of those went on to be enrolled in the open label extension, and they received 160 milligrams of bimekizumab every 4 weeks. So for the purpose of this study, we defined the pandemic as the 11th of March, which is the date that the World Health Organization declared it a pandemic. And at that point, most patients have been on bimekizumab for around 3 years. And so this analysis presents data from September 2019 through to April 2021. And the two primary things we're reporting is the BASDI and the AS-QOL from the start of the pandemic, as well as mean scores during the pre-pandemic and pandemic period. So let's look at the results. So the patient demographics and characteristics are shown in table 1, and most patients are from Eastern Europe. The mean age is 42, and they're around 85% males. So it's a typical ankylosing spondylitis cohort, and you can see that HLA-B27 was around 90%. Disease duration is around 5 years. If we look at table 2, these are disease characteristics, both at the baseline of the Be Agile study and also at the start of the pandemic. So you can see there ASDAS-CRP on the entry to the study, and also the ASDAS-CRP at the time when they entered the pandemic. So you can see that the effect of the bimekizumab there, including BASDI, BAS-Phi, and the CRP. You can see all those, the changes across that time period was the effect of the bimekizumab. So if we look at patient outcomes, so changes in the BASDI and the AS-QOL from the start of the pandemic is shown in figure 1A and 1B. So these are the time since the start of the pandemic by patient visit. So I agree, it looks busy because each marker represents a single patient visit. So during the pandemic period between March 2020 and April 21, there were no sort of notable changes seen in either of these different outcomes since the last pre-pandemic visit, which you can see on the left. If we look at patient outcomes, so the mean BASDI and AS-QOL scores during the pre-pandemic and the pandemic period, these are shown in figure 2, and you can see that they remain stable at around sort of 2.4 during the pre-pandemic period to 2.2 during the last pandemic period. And figure 2B shows the stability of the AS-QOL during this period too. So it's a little bit more variable, but there were no significant changes across time. So I think from this data, we can conclude that in patients with ankylosing spondylitis receiving bimekizumab every 4 weeks, and having done so for around 3 years in an open label extension study in Eastern Europe, disease activity as assessed by BASDI and health-related quality of life evaluated with the AS-QOL remained pretty stable during the pandemic. And there were no indications, at least in this data set, which was drawn from mostly Eastern Europe, the Czech Republic, Poland, and Russia, that there were no indicators of negative impacts on at least these outcomes in these studies. So our findings differ from some other real-world studies evaluating impact of the pandemic. And this is obviously a slightly different setting in an open label extension than from real-world studies. But certainly it is reassuring that at least in this data set, and which is potentially more rigorously collected than some real-world data sets, that these two outcomes were stable over time. So thank you very much.
Hi, it's Dr. Kevin Winthrop, infectious disease professor and public health professor here at Oregon Health Science University in Portland, Oregon. I want to thank the CSF gang for allowing me to briefly introduce a poster that I was part of its presentation at the recent ACR meeting that was virtual. This was actually first authored by Richard Howard, and I was part of this team that was evaluating the risks of COVID-19 among patients with spondyloarthritis. And as background, we all know about this COVID-19 pandemic. There's from the beginning been many questions about whether individuals with various rheumatic and musculoskeletal diseases are at higher risk for COVID-19 or severity of COVID-19 presentations based on their disease and or their therapies. And I think what we've learned at this point is there are subgroups of patients at higher risk, but probably most of that is driven by the therapies and not necessarily the underlying disease. This was the first look, or at least the largest look, at individuals with spondyloarthropathy or SPA. The way this was conducted was a little bit different than the Global Rheumatology Alliance and many of the other registries that were out there to help answer this question. Most of those relied on physician reporting. This was actually a direct survey of patients. And from April 10th, 2020 to April 26th, 2021, so roughly a year, we conducted this web-based longitudinal survey of SPA patients, some of whom had COVID-19. Most of these patients were in North America, and these were individuals that are registered within the Spondylitis Association of America, their own registry. And this was our way of distributing this survey. Additional surveys were also distributed based on lists provided by the ASIF, or the Axial Spondyloarthritis International Federation. And of course, we translated the survey into up to 15 languages as needed to accommodate those members. So individuals were asked specifically whether they'd had COVID or not, whether it was molecularly confirmed or not. Demographic factors were collected. Disease activity was asked about, as well as DMARDs that were being used currently to treat their disease. Briefly, our results. So to our knowledge, this was the largest study to date looking at SPA patients in COVID-19. We received responses from over 4,700 subjects with SPA. We also asked the SPA patients to enroll household contacts or household members into the survey as well, as we thought this would be an interesting control group. And we found 450 individuals who participated in the survey that were household contacts with subjects with SPA who'd participated. Most of these individuals were in the US, about 65%, 8% in Canada. The remaining quarter were from 72 other countries. 70% of the US respondents provided longitudinal data. The majority were female, 63%. Median ages were right around 50 or 49 for females and 54 for males. The several forms of SPA were reported, with most patients saying they had ankylosing spondylitis, or 84% of individuals saying they had AS. So many patients reported being exposed to COVID-19, 19.6% during this year, or at the time of their survey. And of those, about 295 had a confirmatory positive test to COVID. And there were a number of patients also who had unconfirmed reports of COVID-19, meaning they weren't tested. And that was, so overall, we had 384 cases, or 8.2% of people either having molecularly confirmed or a suspect case of COVID-19. So in table 1, you can see our main results. This is the analysis of medication usage in our estimates of susceptibility and severity of COVID-19 based on these reports. And what we found is there's a number of cases reported by individuals using the medicines listed in this table. you can see that, the medicine usage here probably reflects the usual meds used in this condition. Many patients on anti-TNF therapy, many patients on NSAIDs, and then fewer patients in other DMARD groups. We put the number of COVID-19 cases in the first column there of the table. You can see that and how they distribute with the reported therapies. We compared the number of cases or the risk or incidence of cases among those DMARD groups with individuals who were reporting no medication use. You can see the rate ratio there and confidence intervals. The bottom line was that none of these DMARD therapies appeared to be associated with a higher self-reported incidence of COVID than no medication at all. One thing I'd point out is there is a bit higher risk ratio with sulfasalazine, 1.53, although this was not statistically significant. We were able to follow that up a bit more with some additional surveys after this time period. There was a correspondence we published in ARD actually very recently commenting on this and also showing that rate ratio went down when we got more data. So we did not find a statistically significant increased risk of either COVID or severe COVID with sulfasalazine in this analysis. Now, this is somewhat distinct from the Global Alliance data, which looked at sulfasalazine across the various conditions. And predominantly in RA, there was a statistically significant increased risk of severe COVID in RA patients using sulfasalazine. The reason for that, none of us know. And I don't think it's real, actually. We don't think sulfasalazine diminishes immune defenses against viruses or really anything else. So it's probably an artifact of residual confounding within RA. Within the AS and SPA data here, we did not see the same effect with sulfasalazine. So again, I think probably within RA, that issue that was seen in the GRA data is probably due to residual confounding. So what about this work here? In summary, we obviously are limited. This is a survey. It's a patient survey. It has inherent limitations with regards to bias, as well as confounding due to a variety of factors. So it is what it is, as my wife likes to say. It's a survey, but I think it's important that we did find that SPA patients didn't seem to be more likely to get COVID than their household controls, which I did not mention that data, but it is buried in the results here that the 450 controls, there was no higher rate of COVID in those individuals than the subjects with SPA. On the other hand, these are small numbers of people, and particularly with the household contacts. I think one unique feature of this analysis is it did capture some longitudinal data over the course of the year. These individuals were surveyed at multiple time points, or many of them were. So that I think that was important. Of course, where this will go and how this will change over the next year, we don't know. We do have a follow-up project looking at vaccine acceptance and hesitancy in this group. Of course, we're hoping that everyone is getting vaccinated, but I'll be able to comment on that to a greater extent later. So I think that probably summarizes this abstract satisfactorily, and I hope you are enjoying the pandemic. Thank you.
Hello, everyone. I'm Athanasios Bakassis from University of Athens in Greece, and I will be presenting data from a study focusing on the clinical presentation and outcomes of COVID-19 in patients with autoimmune and autoinflammatory rheumatic diseases. I would like to thank Professor Mavragani and Professor Moutsopoulos for giving me the opportunity to present our findings today. There are no relevant disclosures. Here's a list of key references to the topic. As known, individuals infected by the novel coronavirus can experience a wide range of clinical manifestations, from no symptoms to critical illness. Based on the NIH classification, the clinical spectrum of SARS-CoV-2 infection is as follows: asymptomatic infections individuals who have been tested positive, but who have no symptoms consistent with COVID-19. Mild illness, individuals who have any COVID-19 related symptom or sign, but no shortness of breath or abnormal chest imaging. Moderate, individuals who show evidence of low respiratory disease during clinical assessment or imaging and who have oxygen saturation above 94%. Severe, patients with low respiratory disease and who have oxygen saturation below 94% or lung infiltrates in more than 50% of their lung parenchyma. Critical, patients with respiratory failure, septic shock, or multiple organ dysfunction. Patients with certain characteristics and underlying comorbidities are increased risk for severe COVID-19. These comorbidities include being aged 65 years or older, smoking, having cardiovascular disease, chronic lung disease, diabetes mellitus, chronic kidney disease, and obesity. But what about this immunocompromised state? Are patients with rheumatic diseases in increased risk for severe COVID-19 by virtue of their disease and its treatment? For sure, some patients are vulnerable to infections due to their underlying rheumatic disease and its treatment. But in case of COVID-19, something might change. Severe COVID-19 is characterized on one hand by an aberrant production of pro-inflammatory cytokines, the so-called cytokine storm, which triggers monocyte and neutrophil recruitment, vascular leakage, and further tissue damage. On the other hand, by an impaired and delayed type 1 interferon production that is otherwise crucial for viral clearance during the early stage of infection. Therefore, it was speculated that anti-cytokine drugs might ameliorate the clinical picture of COVID-19 and that heightened type 1 interferon signature that characterizes certain autoimmune diseases might have been protective. All this motivated the conduction of the following prospective observational study assessing the clinical presentation, the COVID-19 course, and COVID-19 related hospitalization and death in patients with autoimmune and autoinflammatory rheumatic diseases. From the beginning of the pandemic, consecutive patients followed in 4 outpatient rheumatology clinics in the area of Athens in Greece were given a questionnaire, and in case of SARS-CoV-2 infection, were encouraged to notify the treating physician for further guidance. From March 2020 to September 2021, 100 rheumatic disease patients infected by SARS-CoV-2 self-referred to us. The mean age was 50 years old, with the majority of them being females. The most common diagnoses were rheumatoid arthritis, systemic lupus erythematosus, Sjögren's syndrome, systemic sclerosis, and seronegative arthritis. The most common comorbidities included pre-existing lung disease, mostly attributed to the underlying rheumatic disease, hypertension, cardiovascular disease, and dyslipidemia. 3/4 of patients were either asymptomatic on follow-up or had a mild COVID-19 course. 14% experienced a moderate COVID-19 course, while only 15% developed severe or critical illness. The most common symptoms reported were fatigue, low-grade fever, and cough in 57, 41, and 40% of cases respectively. High-grade fever, myalgias, anosmia, headache, and diarrhea was the second most commonly occurring set of symptoms, ranging from 26 to 33% of cases. The median duration of symptoms was 10 days. When patients with severe or critical COVID-19 were compared to patients with asymptomatic, mild, or moderate illness, the former were significantly older, had more frequently pre-existing lung disease, were more often treated with mycophenolate, and experienced high-grade fever and shortness of breath in high rates. On the contrary, patients with mild or moderate COVID-19 experienced low-grade fever and anosmia in high rates. Following multivariable analysis, only age was identified as an independent risk factor for severe and critical outcomes. Similarly, when the 23 hospitalized patients were compared to the 77 patients recovering at home, the former were significantly older, had more frequently pre-existing lung disease and dyslipidemia, were more often treated with mycophenolate and corticosteroids, and experienced high-grade fever and shortness of breath in high rates. On the contrary, low-grade fever and anosmia were once again more often in the non-hospitalized subgroup. Following multivariable analysis, older age, treatment with corticosteroids or mycophenolate, and high-grade fever were identified as independent risk factors for COVID-19 related hospitalization. Among the hospitalized patients, the most common laboratory abnormalities noticed were anemia, lymphopenia, and increased liver enzymes and C-reactive protein. Chest X-ray abnormalities were noticed in 70% of hospitalized patients, with the majority of them having lung infiltrates in less than 50% of the lung parenchyma. Of note, only 60% of hospitalized patients developed hypoxemia and needed oxygen supply. When patients with autoimmune diseases were compared to patients with autoinflammatory diseases, no differences were noticed. In this case series, only one disease exacerbation was noticed regarding a young male patient diagnosed with a periodic fever syndrome, otherwise in remission on colchicine. After infection, he developed a generalized skin rash accompanied by arthralgias at the peak of the fever, a symptomatology that completely subsided following an increase in colchicine dose. Of note, the two patients in critical condition presenting all risk factors for COVID-19 related hospitalization and death, while only one death occurred. So, in conclusion, in this relatively small observational study, and in line with other published literature, it was shown that the majority of rheumatic disease patients present with mild COVID-19. Non-specific symptomatology like fatigue, low-grade fever, and musculoskeletal complaints are common, and thus we should be highly alert. Comorbidities like older age and pre-existing lung disease and treatment with corticosteroids and mycophenolate are risk factors for COVID-19 related hospitalization. Mortality seems to be generally similar to the one observed in the general population, while disease flares are rather an infrequent phenomenon. Thank you for your time.
My name is Kelly Gavigan. I am the Manager of Research and Data Science with the Global Healthy Living Foundation. I work primarily in research, primarily with our Arthritis Power Research Registry app. And I work primarily in analyzing and managing the data that we collect from the research registry from over 34,000 patients who are part of Arthritis Power. And I also work on research studies, much like the one that I'll be discussing today. So the abstract that I'm discussing today, presented at ACR, is changes in patient-reported outcome scores during the COVID-19 pandemic, data from the Arthritis Power Research Registry. So as a little bit of background, basically we've known since early on in the COVID-19 pandemic that patients with autoimmune and rheumatic diseases are at an increased risk of infection. And this has created a heightened sense of isolation among these patients because many follow strict social distancing protocols. So our objective for this study was to determine whether the mean patient-reported outcome scores for mental, social, and physical health fluctuated throughout the COVID-19 pandemic among the autoimmune rheumatic disease patients in our Arthritis Power research registry. So Arthritis Power is an online registry that's used both for research purposes, but it's also used for patients to track their symptoms, their medications, and just their overall disease management over time. So for the purpose of this study, we looked at the results of physical, mental, and social health PROMIS measures among Arthritis Power participants between the months of January 2020 and April 2021. And we looked at participants who provided at least 2 sets of PRO assessments during this time frame. And as I said, we used PROMIS measures, which are scored 0 to 100 with the general population mean of 50, and 10 points is the standard deviation of the reference population. So for the study, we tested the null hypothesis, but there was no change in monthly average PROMIS scores across the 15-month period from January 2020 until April of 2021. So we had over 2,200 participants that were included in the analysis, and we had an average of 4.5 observations per participant. We found that scores for anger and anxiety measures were 1 standard deviation higher than the overall study period mean for those measures. And depression scores were 1/2 standard deviation worse than the overall study period mean during the months of May and June of 2020. In terms of social health, we found that social isolation scores were also highest in June, and the emotional support scores were worsened in December of 2020. However, during this time, we found that the physical health assessment scores did not meaningfully vary from the overall mean throughout the observation period. And you can actually see in the poster that the scores for anger, anxiety, depression, and emotional support, which are on the figure, the orange, the yellow dotted, the yellowish green dotted, and the green towards the bottom dotted lines. These scores for these measures have big peaks and dips throughout this period, whereas most of the scores for most of the other measures, which were primarily physical health measures, they're pretty steady along this chart. So it was really clear from our findings that mental health scores fluctuated significantly throughout this 15-month period during the COVID-19 pandemic, especially during the first US wave of the pandemic in spring of 2020. And while it was surprising to us that the scores for the physical health assessments did not meaningfully vary during this time, it was certainly reassuring that the participants' rheumatic disease wasn't worsening throughout the pandemic. However, the mental health concerns and the social support of rheumatic disease patients certainly deserves attention by providers and caregivers, especially during a health crisis like what we're experiencing right now. And the results of this study certainly back that up.
Thanks for joining us for this edition of our ACR Highlights series. I hope you enjoyed these presentations. Make sure to subscribe to CSF podcasts on Apple, SoundCloud, or wherever you get your podcasts, so you don't miss out on our great Congress content or any of our other usual monthly podcasts. You can also visit CSF web pages on cytokinesignaling.com, where you can access a whole range of resources from monthly slide summaries or the latest papers to accredited CME courses and even more content in between. Thanks for listening, and come back often.